Welcome back to another episode of the Modern Patient Experience by Q Squared. I'm your host, James Furbush, and today I am pleased to welcome Kevin Holst, the Chief Revenue Officer from Groups Recover Together. Very excited to have you on the show, Kevin. Thanks for joining.
Great, James. Good to be with you today.
So, I want to start, I think the notion of the patient experience, but as it relates to addiction recovery in America, I mean, that's such a huge topic with, opioid rates and sort of the problem that we're having in America. And so I'd love for you just to kind of talk to us today about, Groups Recover Together, how you guys are different from other addiction treatment organizations and sort of your role there.
Sure. No, I'll be happy to. And you're right. You hit the nail on the head. Over the past 18 months, the opioid epidemic has become much worse through the global pandemic of COVID, right? Addiction is a disease of isolation, and the pandemic has put everybody back into an isolated state by and large. Our role in that space is to help people that are addicted to opioids find treatment. Groups Recover Together is an opioid addiction treatment provider. We are licensed as an OBOT, which is an office-based treatment provider that allows us to deliver in an outpatient model a highly differentiated version, a highly differentiated clinical model of medication-assisted treatment. And what that means is we use a combination of prescription medication to stabilize our members in treatment as we provide what is not often provided in MAT as it's delivered traditionally throughout the country. A very significant focus on building a supportive community of peers around our members through the context of weekly group therapy, and a variety of support services that help our members navigate through snapping their lives back together. So if you think about, the isolation of it, oftentimes when our members come to us, they are, convinced that it is just them, and they walk into a room full of peers that are in a variety of milestones along their addiction or the recovery journey. Once they join that group of peers, they very quickly start to a community through which they are accountable to. The way we get our members to engage in that model of treatment is through 7-day prescriptions where they must come in and attend a weekly group therapy to pick up their prescription to the next 7 days of medication. And through that, we offer individual counseling and individual navigation services that help them do things like, navigate Medicaid to get enrolled into health coverage, navigate social services to help get their children's and families back together, navigate, something as simple, although not often as simple as we like it, navigate the DMV to get their license back so they can drive to their job and begin to, piece back together their lives. And what we've come to find is those things, that aren't necessarily focused on, a one-on-one physician office visit or a definitive test that's sent to a laboratory, which often pay well in the context of fee schedules through healthcare insurers, are the things that drive the most value and are the most sticky for our members, that helps them gain traction and helps them achieve long-term recovery.
Nice. Yeah, that's incredible. So how do your patients come to you guys? Is it
Sure.
references from the hospitals and health systems or like, I'm just very curious how you sort of reach out to sort of help this patient population.
Sure. It's a tricky proposition in terms of being relevant to folks that are often isolated and often in the midst of an addiction which makes it very difficult to reach them. In our existing and more mature markets, the flywheel of our members referring others to us that are in need of is a big part of how we gain access to growing our members and census. For our expansion markets that we're new to, I mean, we don't have a ton of awareness and we don't have a ton of census to generate those member referrals. We do a variety of paid acquisition strategies through, paid search on Google, through social channels like Facebook, Instagram, and, paid recovery influencers where there's a significant number of folks that have generated audiences, based on telling their recovery story and telling their addiction story. And through those channels, we generate demand. And the first touch through those channels is generally into a 24-hour, 24/7 crisis line that is staffed by licensed addiction counselors. And, that's the first touch point. On the other side of that is the awareness that we're building and the relationships that we're building with community stakeholders. If you think about, generally where population of folks that are wrestling with opioid use disorder generally engage in a community, it's the emergency department, usually in the context of some, emergent care like an overdose. It's through local law enforcement and first responders that see these members, in a variety of different situations, often, associated with emergency care. Criminal justice. We do a lot of work with county sheriffs and county jails to catch members that are being released from a jail sentence that have been incarcerated due to their opioid addiction. That population is significant. And a population of members or patients, we refer to our patients as that is at high risk, because oftentimes what happens is they are arrested in the context of an active addiction, and they essentially are incarcerated for some period of time through which they are, forced into abstinence, and they become, naive to the opioids that they're used to. And when they're released, oftentimes that's when they are at the most risk for an overdose event, because their body has lost the tolerance that has been built up over the addiction. And they're much more likely to wind up in, either, in the emergency room and to be stabilized, or, oftentimes they're dying in the context of their drug use.
I'm curious. So, I mean, it's a very different patient experience that in some ways, because it sounds like, trust is a big part of that experience for you guys, being able to build that with people who walk through the doors. And then once they're no longer maybe coming in, but then afterwards, right, helping them rebuild their lives so that you don't see them again. Can you, I'd love to just, do you at a high level, can you talk about sort of that sort of journey in terms of, how you're orchestrating sort of building that trust and what you guys are doing differently in order to sort of facilitate that patient experience that
Sure.
to basically enable them to have success, right? To be into recovery and really put their lives back together.
Yeah, I mean, I think the right place to start is to talk about stigma, right? Most of the folks that are, struggling with opioid use disorder have been in addiction for some, a significant period of time. In our membership, it's, somewhere in the order of 11 years, which is mind blowing to think about. And through that process, they've been stigmatized by the U.S. healthcare system. They've been stigmatized by physicians who see them as drugs. Oftentimes, through the distrust of the fact that they've gotten to their active addiction through a legal script from a provider, right? Starts off, 10 years ago with the sports industry that results in a legal script to, Oxycontin that, starts them on through an addiction cycle. So there's a lot of distrust there on both sides. Providers see them as drug seekers. The patients see the providers as drug pushers and, have been referred to as addicts and users and as such. One of the things that we focus on as an organization is using the benefit of doubt with these members to treat them like people. Because oftentimes, these folks have not been. And there's a ton of value in that it's the first step in starting to build trust. Most of our members come to us, feeling as though we are going to stigmatize them because we are a medical provider. And it takes time, sometimes longer than others. It takes time to build that trust back to the point where they believe, they see and learn that they can be inspired by a counselor or learn from a prescribing physician or, figure out pieces of their lives from a patient navigator that helps them, navigate, barriers to long-term recovery, like navigating social services. Once you start to do those things, you start to build that trust. And that's an important component of just getting the member to engage in their care. And once that starts to happen, then and only then can you start to drive the other pieces of the patient experience that are vital, including, there's a ton of clinical complexity here in this cohort, including getting them back on a regimen in a relationship with a primary care provider, getting them back to the dentist to get that process started, managing through specialty care for a variety of things that this cohort is often comorbid with. And that's all part of building out a superlative patient experience. As it's no surprise as you start to feel better physically, and that happens relatively quickly with this patient population. It winds up, as it turns out, even just a month of, stopping the drug abuse that they've been engaging with for that period of time, they look and feel differently. And it's amazing transformation to be able to watch across our membership. But once that starts to happen, then they really start to engage in their care. And not only are they helping themselves kind of in a stepwise approach achieve recovery, they're also a model to the folks that are new to the process. So all of our groups, our group therapy sessions, same group of people, same time, day and time every week, same counselor that our members are coming into. Historically, face-to-face in one of our, bespoke clinics that we've built, and we've built out approximately 85 clinics across the country. But they start to, engage in that group treatment model and begin to, build relationships and build accountability with that, group of peers on a week-to-week basis. But in that context, they're open groups. So the mature members that are further along in their recovery are great, role models and proof points to the folks that are walking in the door for the first time. And for the, folks that are more tenured in their recovery, it reminds them what it looked and felt like when they first started their recovery journey. And that's a very powerful component of the overall model.
How has the last 18 months been I imagine face-to-face, in-person group meetings have been an enormous challenge for you and your members in the last 18 months. What have you guys done to adapt to that on behalf of your patients?
Sure. In a move to keep, both our members and our staff safe in, March of 2020, we essentially shifted to a 100% virtual model very quickly. We had some experience a couple of years before during some of the California wildfires, had to migrate to a virtual model as a lot of our members were displaced in Redding and Chico in Northern California, and we had to quickly lift and shift onto a virtual platform. So we had that experience in March of 2020. We did so for the entirety of our member base, which was a Herculean effort that, quite frankly, I don't remember much. There were a lot of 18-hour days back then, as you can imagine.
That's probably all.
We did so successfully, and we did so in a way that we tried to continue to emulate the member experience, through a platform like this, through a Zoom-like platform, and leveraging our EMR in a way and our calls that tried to closely as possible match the in-person experience that our members were used to. At that point in our growth, we were probably about a little over a quarter, probably 30% of our census today that we are today. We moved from, say, call it 2,500 members that we're seeing on a weekly basis to, just last month, we pierced the 8,000 member mark. And we've done so predominantly with this virtual model. We've continued to open physical locations. In March of 2020, we were probably, 50 locations. We're at 83 now, most of which support our staff, but are not supporting face-to-face care delivery at this point. We had planned to go back this month, but with the progress of community transmission of the Delta, it's become really difficult to do, and we've delayed that till such time that we have good visibility into getting our members back into care, in-person care safely. But the things that we think about from a member perspective, we're an organization that is very focused on driving outcomes, both from the reduction of emergent care for our members, the increase in primary care utilization, typical HEDIS measures of making sure that our members are, getting into treatment quickly from the time that they engage with us to the time that they're actually being seen. All those things are a big focus for us. Making sure that we had parity when we shifted to a virtual model was critical to our success. The contracts that we sign with payers are tied to the success of the metrics that I just listed, and we've been able to do so in a virtual model to date.
So reimbursement's not tied to whether it's physically in person or digitally, but more outcome based.
That's correct. I mean, we're, in some states that is by virtue of the fact that, executive orders have made that true. In other cases, we're contract with payers in a way that allows us to support virtual and will moving forward. It's interesting. We're trying to watch the regulatory and, landscape as closely as possible to see how this distills. And I think, like most organizations, we're convinced that it'll be some type of hybrid model moving forward. I don't know that anyone thinks that we'll be able to put that genie back in the bottle.
Have you guys been able to look at like attrition rates or how your members showing up to groups and treatment, like in person versus digital? I'm curious if you guys have been able to look at that and how does that compare from one to the other?
Sure. There's three, sentinel metrics that we focus on from an outcomes perspective that are related. I mean, there's other stuff with regard to, utilization and cost reduction that we focus on, but the three big ones in terms of, early tells of success of our program are attendance to our weekly group, which has actually improved in the remote model because we've, stripped away one of the barriers of social determinant barriers, which is transportation, right? It's easier for somebody to get to their weekly group treatment through our remote and our virtual platform. The second is abstinence from illicit opioids. So we've continued to test our members with a point of service urine drugs which is the way we've done it during in-person care as well. And while we have lost a bit of fidelity in the sample, and I'm sure there are ways that our members have figured out how to pass a urine drug screen when it's delivered remotely like this. The reality of it is we see our members once a week, and our members are being seen in the context of a group treatment model. And there is nobody better than, calling somebody out from an accountability perspective than a peer.
Yeah.
Right. Additionally, the counselor engaging with these members on a week over week basis solves for that to a certain extent. But, we think it will continue to be a vital piece of the way we deliver care, and being a little bit more rigorous around that as we get back in-person care is important. The other piece that we track is retention and treatment in 6 months. We measure, from the first day of treatment through 6 months, the percentage of folks that remain as an early indicator for success of long-term treatment, and where you start to bend the cost curve of keeping members in care is an important component. And with groups, that average sits around 72% of members retained at treatment at month 6. In comparison to medication-only treatment models, which doesn't deliver effective and rigorous counseling services, and doesn't deliver wraparound services like care navigation often. Those models show retention in treatment somewhere around 25 to 30%. So oftentimes we're 2 to 3x the traditional model of, the industry in terms of retention and treatment. And we see that as a big piece of our clinical model, right? The group therapy model that, creates the supportive network, and the work that we do to knock down the long-term, the barriers to long-term recovery, which are often social determinants like transportation and housing and food security, as well as, knocking down and cleaning up, the comorbidities, the physical health of a member, and helping them feel better generally.
Yeah, it's interesting. So when, do your patients always have a relationship with you guys, or what's sort of that handoff when, you can say, or
When
they
they graduate from there.
graduate, yeah, or like feel like they could
Yeah.
kind of go back to the world's a better, healthier person.
Sure, it varies considerably, James. Like if you think about it, everybody's addiction experience varies considerably. For the a member in their 20s that got to their addiction through a sports industry and developed a pill problem. There's no reason why you have to have that person on medication for the rest of their lives. For the member that has lived through a 30-year addiction to heroin, maybe all of our members engage in a shared decision-making model in terms of when they taper the medications, when they stop the medications, and when they believe they don't need to continue to engage with us in any way. The unique thing about our program, and I kind of alluded to it there earlier, is once they taper 100% off the medication, they are open to continue coming to group therapy, weekly group therapy, at no cost to them and at no cost to the health plan. As I mentioned before, really valuable in not only continuing the rigor in their own recovery journey, but also helping others along in theirs.
Well, and I would think too, the being able to go to group or staying in sort of the group therapy, it's also like that accountability model, right? If you still have that, you're probably less likely to maybe relapse if you still have that sort of group of peers that you can check in with
Right.
and get support from and are accountable to.
That's right. That's right.
So, for you as a CRO, what are the things that you are directly responsible? I mean, it probably sounds like you're doing a lot of stuff from making, identifying patients and getting them into the program. But what are sort of the things that fall under your purview as the chief revenue officer related to the patient experience? A little bit of everything.
Yeah. So not everything. I have a great, there's a great leadership team here that we share a variety of different disciplines. My role is ownership of the growth organization. So that includes a couple different things. It includes direct member marketing channels that I mentioned, like the paid acquisition channels that we leverage, traditional media that includes, everything from billboards to connected TV to, remnant, you know, overnight TV spots to, building out and enabling a team that is on the ground, talking to community stakeholders and all the, the white papers and trifold brochures and all the stuff that we need to be able to describe who we are, what we do, and the differentiation of our model in comparison to others. It also includes the payer partnerships that, post contract, my team is responsible for standing up the payer contracts to make sure that we are set up properly in the payer systems, that we are, ready to be able to drop claims on behalf of our members once we're live and credentialed, and the ongoing reconciliation of at-risk agreements that we have with a variety of different payers. So justifying the cost and the impact that we're making on total cost of care for the membership by plan.
Yeah. How, I'm kind of curious. So those discussions with payers, what are those like? I would assume they would have a vested interest in keeping people within their network out of the emergency room, for example, or utilizing hospitals and things like that. So how do those negotiations or deals work with payers?
Yeah, I mean, generally, we're taking at risk in a bundled payment, which is groundbreaking when you think about, Medicaid is 60% of our overall payer mix. And we've done some really good work with some innovative, Medicaid payers across the country. And, a lot of that discussion is around, how we can impact the overall cost of this patient population, which by and large, as I mentioned before, you know, they've been divorced of the American healthcare system. Like generally, the payers have a really difficult time of, even engaging with them in to be able to direct them towards, lower cost of care or appropriate level of care. One of the things that we do extremely well is we can engage and connect with folks that are living with addiction, through the channels that I mentioned. But once we get them in treatment, we are much more successful in bending the curve in terms of overall cost for this patient population, which is generally the value that we represent to the payer. And on an ongoing basis, quarterly, we are meeting with our payer partners to go through growth in census, to go through the impact that we're having on costs through evaluation of the metrics that we are taking risk on, as well as, more and more getting in discussions around how we're bending the curve on total cost of care.
Yeah, that's awesome. And so, you guys have had, obviously it sounds like, incredible growth this year, and probably due in no small part to, COVID and the isolation and certain things like that. But as you're looking ahead, what are your sort of priorities, initiatives for the patient experience at groups, heading into 2022? Do you have stuff that's sort of on the roadmap for you guys that you're looking to tackle?
Yeah, we do. I mean, we are, you've hit us at a really good moment in time. As I mentioned before, we staff a 24/7 crisis line, which is, where most of our engagement starts. That team just last a week migrated onto our Salesforce platform, which will give us a ton of ability to maintain relevance and connection with members in various places of their recovery. Not only once they are in care with us, but oftentimes the first call isn't the call that gets the, prospective member in the, it's often, folks are calling because they're in distress or they need, immediate attention because they're in active withdrawal. If we can grab them, then great. But oftentimes it's an ongoing nurture campaign to be relevant to this member population. Investing in that piece, in the automated connection piece to our members, and figuring out how to optimize that over the next coming quarters is a big part of our overall strategy. As I mentioned before, we do some work with recovery influencers. Jessica Kent, if you haven't seen her online, well-known voice in the recovery community, and has told her story, to the millions of followers that she has through TikTok and, YouTube and Facebook and Instagram. But she has agreed to represent groups because she believes, in our model, in our harm reduction model and the way that we engage with our patient population. We're looking to grow those type of engagements with our members and, quite frankly, try to meet them where they are. One of the other channels that we engage in is more kind of grassroots, and it's from our, from the beginning days of groups in New Hampshire, is flyering, posting up pull tab flyers in places where folks that are struggling with addiction congregate. And that's often, retail establishments that are open 24/7, laundromats, convenience stores, McDonald's, fast food bathrooms, gas station bathrooms, where folks generally are using. And that kind of grassroots stuff has kind of fallen off through COVID for all the reasons you can imagine, of just being safe and getting out into the community. We're investing heavily as an organization in a program called Everybody Flyers. So everybody, from my CEO all the way down to the newest employee, has a responsibility for generating awareness in their community. And that's another piece, of how we continue to build relevance to this patient population over time.
Yeah, it's so fascinating to think about how to meet patients where they are. Because I even think about too, like, not everyone has access to technology, right? So even thinking about like, can patients even do like virtual calls? And some might not be able to, right? I mean, that's probably a little bit of a challenge. Not everyone.
Yeah, we were, that was a big worry back in March of 2020 when, a lot of the rural communities where we focus on high need, low access to quality care don't have good bandwidth. Often these folks are, have lost everything, including income and families, et cetera, don't have an ample bandwidth or a cell phone or a smartphone to be able to dial in. We found that, that percentage was smaller than we thought it might be.
Yeah.
But there's a variety of different, programs that are out there to help folks, get access to a phone, get access to bandwidth, even if it's going, a place where they can sit in their car outside a public library and be able to dial in. That's what's, a lot of innovative ways to be able to solve for that. For our justice involved population, especially in the state of Maine, we're actually buying burner phones, short-term, temporary phones. So at least at release, the first phone call that they can make is to groups to make sure they know how to get to their first group counseling appointment. So we've tried to look at it in a variety of different innovative ways that we can scale, but it wasn't as big as a problem as we had feared it might be.
Yeah, I mean, at this point, I think so many people, let's say almost, I would think most people have some sort of smartphone or some kind of phone at the very least at this point. Do you have, I'm curious, because one of the challenges I think, right, in talking about the patient experience is in some ways it's like we talk about it monolithically, right? Do you guys have buckets that you place patients in and think about like, I mean, you probably have a million different personas and things like that, but do you sort of at a high level, are there buckets that you think about with the patients, or have you done any of that sort of segmentation work? I'm curious.
Sure. Look, the clinical model has a variety of different sides. There's a stabilization phase, there's a maintenance
Yeah.
phase. Just to consider, how we look at our patient population that is in treatment. There's also, kind of a bucketed approach to thinking about, where patients are in finding recovery.
Yeah.
Are they in a position where they think they have a problem and, need help? Are they convinced that they do and they're actively searching for the right treatment model for themselves? We look at it, from that perspective a lot of the time. But and we get a lot of feedback from our members. They're the ones that are most connected to the overall worldview of folks that have wrestled with addiction, and we try to make sure that a big input to the way we look at engaging with patients over time.
Yeah, no, that's great. I think that makes sense. Thinking about kind of their stage of their recovery journey more than sort of the actual person themselves. How do you, for you as a leader, at Groups Recover, but healthcare generally, where do you go to find inspiration? Or like, are there places that you go to look at that ideas to steal or companies that are doing stuff that, you're like, I want to stash that away and maybe bring that to groups at all. I'm curious where you go to find ideas and related to the patient experience.
Sure. I think the biggest source of inspiration for all of us here are the members that we serve and the journey that they've had, the amount of barrier and hardship and grief that a lot of our members have lived through is significant, and that's a big source of inspiration. Followed shortly by the team that we have in the field, our counselors, the addiction counselors that see our patients on a weekly basis and become kind of the inspiration for our members are another great source. You know, a lot of our counselors have connection, to addiction, either through their own recovery or the recovery of close family and friends. All of them have lost patients. And we try to honor that as best we can because they are, they're the rock stars within the context of our organizations. They're the ones that are making a difference and making the impact of of the lives of the members who trust us in their recovery journey. Barring that, there's a number of, marketing professionals and, that we've engaged with to try to learn, things that they've found successful, that, not non-competitive organizations that are, that are in healthcare that we see as innovators with regard to how to effectively engage patients in their treatment.
Nice. Well, Kevin, thank you for making the time to talk to us about groups and your work. I mean, it's an inspiration. It's really important, the work that you guys are doing, impacting the lives that you are. And so thank you for sharing and appreciate you coming on today to talk us through some of this stuff. So thank you.
Sure. Pleasure being here, James. I hope you got enough to be relevant and good seeing you again.
Yeah, it's awesome. All right. Take care, Kevin.
See you.